Describe your experience with different types of ventilators.
My experience with ventilators is extensive and spans a variety of models and modes of ventilation, as it is a core component of critical care nursing. I have managed patients on a range of ventilators, including brands such as Puritan Bennett and Hamilton, gaining proficiency in their specific user interfaces and capabilities. My expertise extends beyond the equipment itself to the clinical application of mechanical ventilation for diverse patient populations, from those in acute respiratory distress syndrome to post-surgical recovery. I am highly skilled in titrating and managing different ventilation modes. For instance, I am comfortable with volume-controlled ventilation to deliver a consistent tidal volume and pressure-controlled ventilation to limit airway pressure, choosing the appropriate mode based on the patient's specific pulmonary condition. I also have significant experience with pressure support ventilation and synchronized intermittent mandatory ventilation, SGMV, for patients in the weaning process. I understand how to interpret and adjust settings based on a patient's arterial blood gas results and clinical presentation, ensuring optimal gas exchange and patient comfort. In my daily practice, a key part of ventilator management involves meticulous patient assessment. I continuously monitor a patient's respiratory effort, breath sounds, and vital signs, responding to alarms with a swift and accurate determination of their cause, whether it's a circuit leak, a kinked tube, or a change in the patient's condition. Furthermore, I am a firm advocate for implementing protocols to prevent ventilator-associated pneumonia, VAP, including proper oral care, head-of-bed elevation, and daily sedation vacations. My comprehensive experience ensures that I can safely and effectively manage mechanically ventilated patients while collaborating closely with the respiratory therapy team and physicians to provide the highest standard of care.
Walk me through the steps you take to manage a patient in septic shock.
Managing a patient in septic shock is a time-sensitive, multifaceted process that requires immediate and coordinated action. My approach is systematic, beginning with immediate recognition and a rapid escalation of care. The moment I suspect septic shock based on vital signs like persistent hypotension, tachycardia, or signs of organ dysfunction, I immediately alert the physician and the rapid response team. This is the most crucial first step, as timely intervention is key to a positive outcome. Following this, I initiate the core components of the sepsis bundle within the first hour. This includes obtaining 2 sets of blood cultures from different sites to identify the causative organism before administering antibiotics. Concurrently, I'd begin aggressive fluid resuscitation, starting with an initial bolus of crystalloid solution to restore intravascular volume and improve tissue perfusion. Throughout this, I am continuously monitoring the patient's mean arterial pressure, MAP, heart rate, and urine output to gauge their response to fluids. If the patient remains hypotensive despite adequate fluid resuscitation, my next step is to prepare and initiate vasoactive medications, such as norepinephrine, to support blood pressure. I am skilled in titrating these high-alert medications to maintain a target MAP while meticulously monitoring for any adverse effects. I would also collect a lactate level to assess for signs of anaerobic metabolism and track its clearance. My care would also include providing broad-spectrum antibiotics as prescribed, ensuring the medication is administered promptly. Every action, from fluid administration to medication titration, is meticulously documented to track the patient's response and inform further clinical decisions. This comprehensive, rapid, and collaborative approach is essential for managing this critical condition effectively.
What's your process for titrating vasoactive drips?
My process for titrating vasoactive drips is a systematic approach that prioritizes patient safety, continuous assessment, and a clear understanding of the medication's effects. The moment I am ordered to start a vasoactive infusion, my first step is to verify the order and ensure the medication, concentration, and starting dose are correct. I then double-check the medication with another nurse, as these are high-alert drugs, to prevent any medication errors. Once verified, I program the infusion pump carefully, ensuring that the dose and rate are entered accurately, and confirm the pump settings with my colleague. The titration process itself is driven by continuous patient assessment and real-time monitoring. I focus on the patient's mean arterial pressure, MAP, heart rate, and other hemodynamic parameters, along with their clinical response. For example, if the goal is to maintain a MAP of 65 millimeters of mercury, I will start the drip and monitor the patient's pressure every 5 to 10 minutes, or as per protocol, making small, incremental adjustments to the rate. I am always mindful of the patient's overall status, noting any changes in their skin color, mental status, or urine output, as these can indicate the effectiveness of the drip on tissue perfusion. Communication with the healthcare team is also a crucial part of my process. I will report the patient's response and any titration changes to the physician, especially if the patient is not responding as expected or if the dose is approaching a maximum limit. I document every adjustment I make, including the time, the new rate, and the patient's corresponding vital signs, to ensure a complete and accurate record. This meticulous process ensures that I am safely and effectively managing a patient's hemodynamics while remaining vigilant for any adverse effects or changes in their condition.
How do you handle a code blue situation?
Managing a code blue situation is a high-stakes event that requires a systematic and calm approach, with a clear understanding of my role as part of a highly coordinated team. My immediate response upon discovering a code blue, whether it's a patient in cardiac or respiratory arrest, is to call for help, ensuring that the code team is activated immediately. While waiting for the team to arrive, my primary focus is to initiate basic life support, BLS, protocols. I would check for a pulse and breathing, and if absent, I would begin chest compressions immediately, as high-quality compressions are the most critical intervention in the first few minutes of a code. Once the code team arrives, my role transitions into a more specific and collaborative function within the team. I am proficient in advanced cardiovascular life support, ACLS, protocols, and can function in various capacities during a code. I am comfortable being the primary nurse, providing essential information on the patient's history and recent events to the code leader, or taking on the role of the medication nurse, preparing and administering drugs as ordered. I am also highly skilled at operating the defibrillator and performing cardioversion as directed. My ability to remain calm under pressure allows me to communicate clearly and concisely, ensuring there is no confusion in a chaotic environment. Throughout the entire code, my focus is on maintaining a safe and effective workflow. I ensure that accurate documentation is maintained, including the timing of compressions, shocks, and medication administration. Post-code, I assist with patient stabilization and provide a thorough report to the receiving unit. My experience has taught me that a successful outcome in a code blue situation is not about one person's actions, but about a well-practiced, coordinated team working together seamlessly.
What are some common causes of elevated intracranial pressure, and what nursing interventions would you implement?
Elevated intracranial pressure, ICP, is a serious and life-threatening condition in critical care, often seen in patients with neurological insults. Common causes of elevated ICP include traumatic brain injury, TBI, intracranial hemorrhage such as subarachnoid or intraparenchymal hemorrhage, ischemic stroke, brain tumors, hydrocephalus, and cerebral edema, which can stem from various causes like infection or metabolic disturbances. Essentially, anything that increases the volume of contents within the rigid skull, blood, brain tissue, or cerebrospinal fluid can lead to a rise in ICP. When managing a patient with elevated ICP, my nursing interventions are focused on optimizing cerebral perfusion pressure, CPP, and preventing secondary brain injury. My first priority would be maintaining head-of-bed elevation to 30 degrees, which promotes venous drainage from the head, thereby reducing ICP. I would ensure the patient's head and neck are in a neutral position to avoid compression of the jugular veins. Close monitoring of neurological status is paramount, including frequent Glasgow Coma Scale, GCS, assessments, pupillary checks, and motor responses, as any subtle change can indicate a worsening condition. I would meticulously manage the patient's fluid balance to prevent both dehydration and cerebral edema, often through precise intravenous fluid administration. I would also focus on controlling fever, as hyperthermia increases cerebral metabolic demand and can exacerbate ICP. This might involve administering antipyretics or using cooling blankets. Furthermore, I would work to minimize noxious stimuli like excessive noise, bright lights, or unnecessary procedures that can trigger ICP spikes. Pain and agitation management are also critical, using sedatives and analgesics judiciously to reduce metabolic demands and promote comfort without masking neurological changes. Finally, I would strictly adhere to any prescribed ICP monitoring guidelines, interpreting readings, and collaborating with the physician on interventions such as mannitol administration or hypertonic saline to reduce cerebral edema. These interventions are consistently implemented to safeguard the patient's neurological integrity.
Tell me about your experience managing patients on CRRT, continuous renal replacement therapy, or other renal replacement therapies.
My experience with managing patients on continuous renal replacement therapy, CRRT, is extensive and has provided me with a deep understanding of this complex intervention. I have successfully cared for patients with acute kidney injury and fluid overload, where CRRT was a necessary measure to correct severe electrolyte imbalances and remove excess fluid and uremic toxins. My role extends beyond simply operating the machine. It involves a holistic approach to patient management. A typical day caring for a patient on CRRT involves meticulously assessing their fluid status, vital signs, and access site to ensure optimal circuit function. I am highly skilled in preparing the CRRT machine, priming the circuit with a crystalloid solution and heparin, and initiating the therapy. Throughout the treatment, I am constantly monitoring the patient's hemodynamic stability, as sudden fluid shifts can lead to hypotension. I am also responsible for titrating the rate of dialysate and ultrafiltration based on the physician's orders and the patient's real-time needs. This requires a high degree of vigilance and critical thinking to respond to any changes in the patient's condition. Furthermore, I am adept at troubleshooting common issues with the CRRT circuit, such as filter clotting or air in the line. I know how to safely and efficiently replace a clotted filter to minimize downtime and maintain the therapy's effectiveness. My experience also includes managing the anticoagulation of the circuit, adjusting heparin or citrate to prevent clotting while avoiding bleeding complications in the patient. I have also cared for patients on other renal replacement therapies like intermittent hemodialysis, giving me a broad perspective on managing renal failure. This comprehensive experience has equipped me with the skills to provide the highest standard of care to critically ill patients requiring renal support.
How do you use tools like the RASS, Richmond Agitation Sedation Scale, and CPOT, Critical Care Pain Observation Tool, to manage a patient's pain and sedation?
In critical care, effectively managing a patient's pain and sedation is paramount, especially for those who are intubated or unable to verbalize their needs. I consistently utilize objective tools like the Richmond Agitation Sedation Scale, RASS, and the Critical Care Pain Observation Tool, CPOT, to guide my assessment and intervention strategies. These tools provide a standardized and evidence-based approach, minimizing subjectivity and ensuring appropriate patient comfort and safety. My process begins with a thorough assessment using the RASS. This scale helps me determine the patient's level of sedation or agitation, ranging from unrousable to combative. I observe the patient's spontaneous movements, response to verbal stimulation, and reaction to physical stimulation to assign a score. This RASS score then guides my titration of sedative infusions, aiming for a light sedation target whenever clinically appropriate, as prolonged deep sedation can lead to negative outcomes like delirium and extended ventilation days. For example, if a patient is agitated, RASS +2, I would collaborate with the physician to adjust their sedative drip to achieve a lighter, more comfortable state, aiming for a RASS of 0 or -1. Concurrently, I employ the CPOT to assess pain, particularly in nonverbal patients. This tool evaluates 4 key behavioral indicators: facial expression, body movements, muscle tension, and compliance with the ventilator or vocalization for non-ventilated patients. Each indicator is scored, An accumulative score helps me identify the presence and severity of pain. For instance, if a patient on the ventilator shows grimacing, restless movements, and an inability to tolerate the ventilator, I would interpret a higher CPOT score as an indication of pain. Based on this, I would administer appropriate analgesia, then reassess the patient's CPOT score to evaluate the effectiveness of the intervention. By using both RASS and CPOT, I can create a comprehensive picture of the patient's comfort level, ensuring I am providing optimal pain relief while avoiding excessive sedation, thereby promoting earlier liberation from mechanical ventilation and reducing the incidence of delirium.
Describe your role and responsibilities as part of a rapid response team, RRT.
My role and responsibilities as part of a rapid response team, RRT, are centered on swift, decisive action and expert clinical assessment to prevent a patient's condition from deteriorating into a code blue event. When an RRT is activated, my primary role is to be the first point of contact and provide an immediate, focused assessment of the patient. I quickly gather all pertinent information from the primary nurse and perform a head-to-toe assessment, focusing on the ABCs, airway, breathing, and circulation, to identify the root cause of the patient's instability. My responsibilities go beyond just assessment. I am proficient in initiating immediate interventions to stabilize the patient. This includes administering emergency medications as ordered, setting up necessary equipment for airway management, or initiating fluid resuscitation to address hypotension. I am also skilled in interpreting vital signs, lab results, and cardiac rhythms in real time, which allows me to provide concise and accurate updates to the RRT physician. This clear communication is critical for the team to make informed decisions quickly. As part of the team, I also serve as an expert resource for the bedside nurse. I provide guidance, reassurance, and hands-on assistance, helping them manage a stressful situation. I ensure that all interventions are properly documented and that the patient's care plan is updated to reflect the new orders. My role is to not only stabilize the patient in the moment, but also to ensure they have the appropriate level of care going forward, whether that means a transfer to a higher acuity unit or a modified care plan on the current floor. My experience on the RRT has honed my skills in critical thinking, leadership, and collaboration, allowing me to be a highly effective member of a team dedicated to saving lives.
What is the ABCDEF bundle, and why is it considered a standard of care in the ICU?
The ABCDEF bundle is a collection of 6 evidence-based interventions designed to improve outcomes for critically ill patients in the intensive care unit, ICU. The acronym represents assessment, prevention, and management of pain, both spontaneous awakening and spontaneous breathing trials, choice of analgesia and sedation, delirium assessment, prevention and management, early mobility and exercise, and family engagement and empowerment. This bundle moves beyond traditional care models by promoting a more holistic and patient-centered approach. The ABCDEF bundle is now considered a standard of care in the ICU because it addresses the most common and devastating issues patients face in this setting. Historically, patients in the ICU were kept deeply sedated, which was thought to be comfortable but often led to prolonged mechanical ventilation, increased risk of delirium, and long-term cognitive and physical impairments known as post-intensive care syndrome, PICS. By integrating these 6 components, the bundle provides a framework for healthcare teams to proactively manage pain and agitation, minimize the use of heavy sedation, and get patients moving sooner. From a nursing perspective, implementing this bundle is a collaborative effort. I actively use the pain and sedation scales to ensure appropriate medication use, and I conduct spontaneous awakening and breathing trials daily with the team to facilitate extubation. My role also involves frequent delirium screening using tools like the Confusion Assessment Method for the ICU, CMICU, and promoting early mobility, even for ventilated patients. Most importantly, I serve as a bridge to the family, educating them and involving them in the patient's care decisions, which has been shown to reduce a patient's anxiety and improve their overall recovery. This systematic approach not only enhances patient safety and comfort, but also leads to shorter ICU stays and better long-term outcomes.
How do you screen for and manage ICU delirium in a critically ill patient?
To screen for and manage ICU delirium in a critically ill patient, I rely on a systematic, evidence-based approach that is both proactive and reactive. The first and most critical step is early and consistent screening using a validated tool. I regularly use the confusion assessment method for the ICU, CMICU, which is designed for nonverbal patients. This involves a four-step process where I assess for an acute change in mental status, inattention, disorganized thinking, and an altered level of consciousness. A positive CMICU result prompts immediate intervention. The management of delirium is multifaceted and focuses on non-pharmacological interventions as the first line of defense. My priority is to identify and address any reversible causes. This includes ensuring the patient's pain is well controlled, checking for electrolyte imbalances, and discontinuing or minimizing medications that can contribute to delirium, such as benzodiazepines. I also focus on promoting a normalized sleep-wake cycle by minimizing noise and light at night and maximizing natural light exposure during the day. I would reorient the patient frequently by telling them the time, date, and their location, and encouraging them to use their glasses or hearing aids to improve sensory input. Early mobility is another cornerstone of my management strategy. I work with the physical and occupational therapy teams to get the patient moving as soon as it is safe to do so, even if it's just dangling their feet over the side of the bed. This helps reduce long-term cognitive and physical decline. Finally, I actively involve the patient's family, as their presence and familiar voices can be incredibly comforting and reorienting. Pharmacological interventions are used as a last resort and with extreme caution, only when non-pharmacological methods fail to control severe agitation that poses a risk to the patient or staff. This comprehensive approach is how I work to prevent and manage delirium, improving the patient's overall outcome.
Describe your process for managing a patient on a high-flow nasal cannula who is showing signs of respiratory distress.
Managing a patient on a high-flow nasal cannula, HFNC, who is showing signs of respiratory distress requires a swift and systematic response to prevent further deterioration. My process begins with an immediate bedside assessment. I first check the patient's vital signs, specifically their respiratory rate, heart rate, and oxygen saturation. I also perform a rapid physical assessment, looking for signs of increased work of breathing, such as nasal flaring, accessory muscle use, and paradoxical breathing. I also assess their level of consciousness, as altered mental status can be a sign of hypoxemia. Based on my assessment, my first intervention is to optimize the HFNC settings. I would increase the flow rate and the FiO2 fraction of inspired oxygen to the maximum tolerated levels, as per hospital protocol and physician's orders, to see if the patient responds. While doing this, I would also ensure the cannula is properly positioned and that there are no kinks in the tubing. Simultaneously, I would reposition the patient, often putting them in a high Fowler's position to improve lung expansion and gas exchange. I would then reassess their respiratory status within a few minutes to see if there has been any improvement. If the patient's respiratory distress continues to worsen despite these initial interventions, I would immediately escalate the level of care. I would contact the physician or activate the Rapid Response Team, RRT, to prepare for potential intubation. I would ensure all necessary equipment for airway management is readily available, including an intubation tray, bag valve mask, and suction. I would also perform a final, comprehensive handoff to the team, providing them with a concise summary of the patient's history, their current status, and the interventions already attempted. This structured, proactive approach ensures that I can provide the best possible care, moving quickly from assessment and optimization to escalation when necessary.
What are your first actions if a patient on a heparin drip has a sudden, significant drop in their platelet count?
My first actions if a patient on a heparin drip has a sudden, significant drop in their platelet count would be immediate and systematic, driven by the suspicion of heparin-induced thrombocytopenia, HIT, a severe and potentially life-threatening complication. The very first action I would take is to stop the heparin drip immediately. This is the most crucial step and takes precedence over all other tasks, as continued heparin administration could worsen the condition. Concurrently with stopping the drip, I would promptly notify the physician and my charge nurse or a senior colleague. I would provide a concise and clear SBAR, situation, background, assessment, recommendation, report, informing them of the patient's current platelet count and the immediate action taken. While awaiting further orders, I would perform a rapid but thorough physical assessment of the patient. I would specifically look for any signs of thrombosis, such as new pain, swelling, or redness in an extremity, which could indicate a blood clot, as HIT paradoxically causes clotting despite low platelets. I would also check for any signs of new or unusual bleeding, such as petechiae, ecchymosis, or blood in the urine or stool. Once the physician is aware, my next priority is to collaborate on a plan to transition the patient to a non-heparin anticoagulant, such as argatroban or bivalirudin. I would ensure that all other sources of heparin, including heparin flushes used to maintain patency, are also discontinued. I would also ensure that blood work, including a platelet count and a specific HIT antibody test, is sent to the lab. Finally, I would meticulously document every step of my intervention, the time of the platelet drop, the physician's orders, and the patient's response. This proactive and highly vigilant approach is essential for mitigating the serious risks associated with a sudden drop in platelets on a heparin drip.
Tell me about a time you had to troubleshoot a persistent ventilator or hemodynamic monitoring alarm.
In a critical care environment, troubleshooting a persistent alarm is a frequent task that requires a systematic and calm approach. A time that particularly stands out was when a patient on a ventilator kept alarming a high respiratory rate, despite showing no outward signs of respiratory distress. The continuous alarm was not only disruptive but also a potential source of alarm fatigue, so I knew I had to resolve the issue quickly and methodically. My first step was to not silence the alarm, but to assess the patient, not the machine. I checked the patient's respiratory rate manually and observed their breathing pattern, noting they were calm and not tachypneic. This confirmed that the alarm was not a true physiological crisis. Next, I began to troubleshoot the equipment. I checked for common culprits: a loose connection in the ventilator circuit, a kink in the tubing, or a leak in the cuff of the endotracheal tube. I also checked the ventilator settings themselves to ensure they were appropriate for the patient's current status. After confirming all connections were secure, I realized the issue was more subtle. The patient had begun to wean and was taking more spontaneous breaths. The ventilator was still set to a mandatory mode, and the rapid succession of the patient's spontaneous breaths with the machine's breaths was triggering the alarm. My intervention was to adjust the ventilator mode to a more supportive one, such as SGMV, which better accommodated the patient's increased respiratory effort. I also recalibrated the high respiratory rate alarm to a slightly higher, more appropriate threshold, while still maintaining patient safety. This simple adjustment resolved the persistent alarm, reduced alarm fatigue for the entire team, and better supported the patient's weaning process. This experience reinforced my belief that effective troubleshooting involves moving beyond a simple alarm and getting to the root cause of the issue.
How do you approach a patient who is intubated but has been pulling at their restraints?
My approach to an intubated patient who is pulling at their restraints is systematic and patient-centered, as it is a critical sign of distress that needs immediate investigation, not just a physical response. My first action would be to perform a rapid and thorough assessment of the patient's underlying cause for agitation. I would not simply resecure the restraints. A patient pulling at their restraints could be a sign of pain, anxiety, hypoxemia, delirium, or that they are ready to be extubated. I would assess their vital signs, particularly their oxygen saturation and heart rate, and check their ventilator settings to ensure they are not fighting the vent. I would also assess pain using an objective tool like the Critical Care Pain Observation Tool, CPOT, looking for facial grimacing, muscle tension, or restless body movements. If I find a reversible cause, I would address it immediately. For example, if I suspect pain, I would administer an appropriate analgesic as prescribed. If the patient appears to be ready for a spontaneous breathing trial, I would collaborate with the respiratory therapist and physician to assess readiness for extubation. Simultaneously, I would speak to the patient in a calm and reassuring voice, explaining who I am and what I am doing, as they are often disoriented and terrified. I would also consider non-pharmacological interventions like providing a sense of orientation by telling them the time and date, or having a family member at the bedside. If the patient's agitation is extreme and non-pharmacological interventions fail, I would collaborate with the physician to administer a sedative to ensure their safety and prevent self-extubation. My goal is always to find the root cause and provide comfort, reserving physical restraints and sedation as a last resort, as they can contribute to delirium and increase the patient's anxiety. This comprehensive approach ensures that the patient's needs are met and they are treated with dignity and compassion.
Tell me about a time you made a medication error. What happened, and what did you learn?
While I have never made a medication error that resulted in patient harm, I did have a near miss early in my career that taught me a valuable lesson about the importance of strict adherence to protocols. I was preparing to administer an oral medication to a patient and, in a rush, I inadvertently pulled a medication with a similar-looking name from the Pyxis. I was about to administer it when I paused to perform my final check, the 5 rights: right patient, right drug, right dose, right route, and right time. When I double-checked the drug name against the patient's electronic medical record, I immediately noticed the discrepancy. I had selected a medication with a similar name and strength, but for a different patient. My immediate action was to discard the incorrect medication, retrieve the correct one, and then administer it to the patient. Following this, I reported the near miss to my charge nurse and documented it in our hospital's incident reporting system. This wasn't about getting in trouble. It was about ensuring the system's safety and preventing a similar error from happening again. The biggest lesson I learned from this experience was the critical importance of a meticulous process, regardless of how busy or rushed I am. I now make it a non-negotiable habit to perform a triple check. First when I retrieve the medication, second when I prepare it, and a final check at the patient's bedside, directly comparing the medication to the electronic health record. This near miss reinforced my commitment to vigilance and has made me a more careful and conscientious nurse. It's a reminder that shortcuts are never worth the risk when it comes to patient safety.
Describe a time you disagreed with a physician's orders. How did you handle the situation?
A time I disagreed with a physician's orders was regarding a patient's pain management plan in the post-anesthesia care unit. The patient, who had a history of opioid tolerance, was prescribed a standard dose of an opioid analgesic. Following administration, the patient continued to show objective signs of severe pain, including elevated heart rate and blood pressure, along with restless movements, despite being unable to verbalize their discomfort. I was concerned the prescribed medication was insufficient to manage their pain, which could lead to a less stable recovery. My first step was to approach the physician respectfully and in a private setting. I calmly presented my clinical assessment, focusing on the objective data from the patient's vital signs and my observations of their physical distress. Instead of directly stating, "I disagree with your order," I framed it as a collaborative problem-solving discussion. I said, "I'm concerned the patient is in significant pain based on their vital signs and physical cues. I believe they may require a higher dose or a different analgesic, given their history of tolerance." I provided a clear and concise rationale for my concern and proposed an alternative course of action. The physician listened to my assessment and clinical reasoning. We discussed the patient's history and the potential risks of increasing the dose. Based on the evidence I provided, the physician agreed to adjust the pain medication order. I administered the new dose, and the patient's vital signs and signs of distress improved significantly. This experience taught me the importance of being a patient advocate, using evidence-based communication, and maintaining a professional and respectful demeanor, even when I have a differing opinion. It is a reminder that patient safety is a collaborative effort and that a strong nurse-physician relationship is built on mutual trust and respect.
How do you prioritize care for multiple critically ill patients?
Prioritizing care for multiple critically ill patients is a constant and dynamic process in the ICU, requiring a systematic approach grounded in continuous assessment and critical thinking. My primary principle for prioritization is always patient acuity and the potential for rapid deterioration. I don't just prioritize based on who is sicker, but rather who is at the highest risk of immediate harm or who requires the most urgent intervention to prevent a negative outcome. My process begins with a rapid, yet thorough, assessment of all my assigned patients at the start of the shift and continuously throughout. This involves reviewing their vital signs, recent lab results, current ventilator settings, and any active infusions. I also perform quick bedside rounds to visually assess their mental status, respiratory effort, and overall appearance. This initial overview helps me identify which patient demands immediate attention versus those whose needs can be addressed slightly later. For example, if one patient's oxygen saturation is suddenly trending downwards and their respiratory rate is increasing, while another patient needs routine medication, my focus immediately shifts to the patient with respiratory distress. I would swiftly intervene to optimize their oxygen delivery, potentially adjusting their high-flow nasal cannula or preparing for intubation, simultaneously communicating with the physician. While addressing this immediate crisis, I also quickly consider which tasks for my other patients can be delegated to a colleague or safely delayed for a few minutes. I rely heavily on effective communication with my team members, including charge nurses and other critical care nurses, to ensure support and appropriate delegation when managing competing demands. The goal is always to allocate my attention and resources to ensure all patients receive timely and safe care, focusing on preventing complications and achieving the best possible outcomes for each individual.
Tell me about a time a patient's family was upset. How did you de-escalate the situation?
A common yet challenging situation in nursing is managing an upset family, especially in the high-stress environment of critical care. I recall a time when I was caring for a patient who had been in the ICU for several weeks. Their family was feeling immense stress and frustration with the lack of progress and the uncertainty of their loved one's condition. One afternoon, the patient's spouse became very upset with me, believing that the patient's lack of improvement was due to a lack of attention. My first and most important step was to avoid becoming defensive. I immediately recognized their frustration was born out of fear and helplessness, not personal animosity toward me. I calmly moved them to a private waiting area to discuss the situation away from other patients and staff. I began by actively listening, letting them express all of their feelings without interruption. I acknowledged their concerns and validated their emotions by saying, "I can see how frustrating and upsetting this must be for you, and I am so sorry you're feeling this way." This simple act of empathy immediately de-escalated the tension and showed them that I truly heard them. After they had finished speaking, I took a moment to explain the care plan in clear, simple terms, detailing the positive progress the patient had made, no matter how small. I focused on what we were actively doing to support their loved one and what they could do to help, such as participating in comfort measures or simply being present. I also made sure to set realistic expectations and offered to connect them with the physician for a more detailed discussion. This collaborative approach transformed the situation from a confrontation into a partnership, and by the end of the conversation, they felt heard, respected, and more in control. It's a powerful reminder that sometimes the best intervention is simply compassionate communication.
Describe a time you had to handle an ethical dilemma related to a patient's care, such as end-of-life decisions.
One of the most challenging ethical dilemmas I faced was caring for an elderly patient with a terminal illness who had expressed a wish to forego further aggressive treatment. The patient had a clear advance directive stating this, but his family was having a very difficult time accepting his decision and was pressuring the medical team to continue all possible life-prolonging measures, including intubation and mechanical ventilation. My role was to act as the patient's advocate and to facilitate clear communication between the patient, his family, and the medical team. My first step was to hold a private, respectful conversation with the patient to confirm his wishes and ensure he was not being coerced. I listened to him and confirmed that his decision was firm and based on his desire for comfort and dignity in his final days. With his permission, I then scheduled a family meeting, including the physician, the social worker, and the palliative care team. During the meeting, I presented the patient's wishes clearly and compassionately, using the advanced directive as the foundation of the discussion. I didn't take sides, but I served as a bridge between the patient's stated goals and the family's emotional needs. I helped the family understand the patient's perspective and explain the significant discomfort and lack of benefit that aggressive treatment would cause. The social worker and palliative care team provided invaluable support in addressing the family's grief and fears. By facilitating open and honest dialogue, we were able to shift the family's focus from aggressive treatment to providing comfort care. The outcome was a peaceful passing for the patient, with his family by his side, respecting his final wishes. It was a difficult situation, but it reinforced my commitment to upholding patient autonomy and advocating for their best interests, especially at the end of life.
Tell me about a time you had to manage a high-acuity patient load when short-staffed. How did you ensure patient safety?
One of the most challenging situations in critical care is managing a high-acuity patient load when short-staffed. A specific instance I recall was during a busy night shift where we had 2 unexpected admissions, leaving us stretched thin. I was assigned to a critically ill patient who was on a ventilator and multiple vasoactive drips, as well as a new admission with a complex neurological condition requiring frequent assessments. The situation demanded a systematic and highly focused approach to ensure both patients remained safe. My first action was to quickly triage and prioritize my tasks. I mentally created a hierarchy of needs based on the potential for patient instability. I designated the patient on the ventilator as my highest priority due to the inherent risk of their condition, knowing their vital signs and drip titrations required constant vigilance. I then communicated with my charge nurse and the other nurses on the floor, sharing a quick, concise update on my patient's statuses and requesting assistance with less critical but necessary tasks, such as obtaining lab work or retrieving supplies. I also leveraged technology and data to my advantage. I set my primary patient's monitor alarms to tighter parameters to alert me to any subtle changes in their condition, and I used my charting time to quickly review all new orders and lab results to identify any potential issues before they became a crisis. I performed my assessments on both patients back-to-back, moving quickly and efficiently between rooms to ensure I had the most current information. By working collaboratively with my team, communicating my needs clearly, and prioritizing based on risk, I was able to manage the workload safely. The outcome was that both patients remained stable throughout the shift, and we were able to provide the high level of care they needed despite the staffing challenges. This experience taught me the true value of clear prioritization and teamwork under pressure.
Describe a situation where you had to quickly learn how to use a new piece of technology or equipment.
During a night shift in the ICU, a new patient was admitted with severe respiratory failure and was immediately placed on a new model ventilator that had just been introduced to our unit. The training for this particular model was scheduled for the following week, so I was faced with a critical situation requiring me to quickly learn how to operate unfamiliar, life-sustaining equipment. My first action was to remain calm and immediately inform my charge nurse and the respiratory therapist on duty that I was not yet trained on the new device. This was an essential step for patient safety and for a collaborative approach. I didn't pretend to know how to use it. Instead, I sought immediate, direct guidance from the respiratory therapist, who was an expert on the new machine. I asked them to walk me through the key functionalities and settings, focusing on the most critical features first, such as how to adjust the ventilator mode, set tidal volumes, and respond to common alarms. As the respiratory therapist explained, I actively listened and took mental notes of the user interface and key buttons. While they were at the bedside, I had them observe me as I operated the ventilator, ensuring I understood each step correctly. I also asked them to point out the specific safety features and troubleshooting procedures for the new model. The next day, I made sure to be the first to sign up for the formal training session, This situation taught me the importance of being adaptable and proactive, as well as the value of leveraging the expertise of my colleagues. It reinforced my belief that in critical care, a team-based approach and a willingness to seek help are vital for ensuring the highest level of patient care.
Tell me about a time your critical thinking prevented a negative outcome for a patient.
A time my critical thinking prevented a negative outcome for a patient was during a night shift when I was caring for a post-operative surgical patient who seemed to be recovering well. The patient was stable, and their vital signs were within normal limits. However, while performing a routine assessment, I noticed a subtle but concerning change in their mental status. They were slightly more lethargic and less responsive than they had been on my previous rounds. This was a soft sign that could have easily been overlooked, but my critical thinking prompted me to investigate further. My first action was to resist the urge to simply document the observation and wait. Instead, I conducted a more detailed assessment, focusing on potential causes for the change. I quickly checked their blood sugar, which was normal. I then looked at their most recent lab results and noticed that their hemoglobin had dropped slightly from the preoperative baseline, but it was still within an acceptable range. Combining this with the change in mental status, my clinical judgment suggested that the patient might be experiencing internal bleeding, a complication that could rapidly escalate. I immediately contacted the surgical resident and reported my findings and concerns. I didn't just report the lethargy. I presented a clear picture, a subtle change in mental status combined with a dropping hemoglobin, even though it was within the normal range. I advocated for a stat hemoglobin check and a closer look at the surgical site. The resident agreed, and the follow-up tests confirmed my suspicions. The patient was taken back to the operating room for a bleed, which was successfully controlled. By recognizing the significance of a subtle change and acting on my intuition, I prevented the patient from going into hypovolemic shock. This experience reinforced the importance of trusting my instincts and using critical thinking to connect seemingly unrelated pieces of data to ensure patient safety.
Why did you choose critical care nursing?
I chose critical care nursing because it is a field that aligns perfectly with my passion for helping others and my desire for a challenging and intellectually stimulating career. The ICU environment demands a unique combination of clinical excellence, rapid decision-making, and unwavering patient advocacy. This is where I feel I can make the most profound impact, caring for the most vulnerable patients during their most critical moments. What truly attracts me to this specialty is the opportunity to become an expert in my field. Critical care requires a deep understanding of complex physiology, advanced technologies, and a wide array of high-acuity conditions. I thrive on the continuous learning that the ICU provides, as no two patients are ever the same. I am motivated by the need to stay current with the latest evidence-based practices and to constantly refine my skills in areas like hemodynamic monitoring, ventilator management, and medication titration. The ICU environment fosters a culture of constant improvement, and I am committed to that journey. Moreover, I am drawn to the strong sense of teamwork and camaraderie that is essential in critical care. In a high-stakes environment, every member of the team must be at their best, working together seamlessly to ensure a positive outcome. I am confident in my ability to be a reliable and collaborative team member, effectively communicating with physicians, respiratory therapists, and other nurses to provide the highest standard of care. This specialty allows me to merge my clinical skills with my deep-seated compassion, empowering me to be a strong advocate for patients who cannot speak for themselves. This is not just a job for me. It is a calling, and I am excited to dedicate my career to this demanding and rewarding field.
What are your greatest strengths and weaknesses as a critical care nurse?
My greatest strengths as a critical care nurse are my calmness under pressure and my meticulous attention to detail. In a high-stress, fast-paced environment like the ICU, a nurse must be able to think clearly and act decisively during a crisis. I have found that my ability to remain composed allows me to perform accurate assessments, prioritize interventions, and communicate effectively with the team during critical situations, which is crucial for ensuring patient safety and a positive outcome. This is complemented by my meticulous approach to every aspect of care, from medication administration to monitoring subtle changes in a patient's condition. I believe these two qualities work together to make me a highly reliable and safe nurse. As for my weaknesses, I would say that I have a tendency to be overly focused on a specific task. For example, when a patient's hemodynamic status is unstable, I can become so focused on titrating drips and monitoring their blood pressure that I may not initially delegate a less critical task to a colleague. I have been actively working on this by intentionally taking a step back in high-stress situations to assess the entire workload and communicate with my team. I now make it a point to verbally delegate tasks to a fellow nurse or technician when I need to concentrate on a critical intervention. This practice has not only improved my time management, but has also reinforced the importance of teamwork and resource utilization. I have learned that asking for help is not a weakness. It is a strength that ensures the best possible care for all patients. I am committed to continuous self-improvement and believe this is an area where I have made significant progress.
How do you handle the emotional and physical stress of working in the ICU?
Working in the intensive care unit is both physically and emotionally demanding, and I believe that managing this stress is a critical component of providing sustainable, high-quality patient care. I approach stress management proactively by focusing on both my professional resilience and personal well-being. Emotionally, the high-stakes environment and difficult patient outcomes can be challenging. I handle this by actively participating in formal debriefing sessions after critical events and by informally connecting with my colleagues. Having a strong, supportive team where we can openly discuss our experiences helps to process difficult situations and prevents emotional burnout. I also make a conscious effort to compartmentalize my day, leaving the emotional weight of my work at the hospital so it doesn't impact my personal life. Physically, the demands of long shifts and strenuous tasks require consistent self-care. I prioritize getting adequate rest and maintaining a healthy diet to ensure I have the energy and mental clarity needed to perform my duties safely. I am also very mindful of using proper body mechanics when lifting or repositioning patients to prevent injury. Outside of work, I have a strong focus on maintaining a healthy work-life balance. I dedicate time to activities that help me decompress and recharge, such as exercising regularly and spending quality time with family and friends. This allows me to step away from the professional environment completely and return to work refreshed and ready to face new challenges. By being intentional about my self-care, I am not only safeguarding my own health, but also ensuring that I can bring my best self to every shift, providing the safest and most compassionate care possible to my patients.
Where do you see yourself in 5 years?
I see myself continuing to grow and develop as a highly skilled and compassionate critical care nurse. Over the next 5 years, my career goals are focused on a combination of clinical mastery, specialization, and mentorship. My immediate priority is to become an expert in my current role, mastering the complexities of a variety of high-acuity patient populations and becoming a trusted resource for my colleagues. I am committed to earning my Critical Care Certified Nurse (CCRN) credential, as this certification demonstrates a deep and evidence-based understanding of the specialty. Once I have solidified my foundation and achieved my CCRN, I aim to pursue a subspecialty within critical care. I am particularly interested in areas such as neurocritical care or cardiac intensive care, as these fields require a very specific and intricate knowledge base. I would seek opportunities to work in these specialized units, attending relevant conferences, and participating in advanced training to expand my expertise. Ultimately, my long-term vision is to transition into a more formal mentoring or leadership role within the ICU. I am passionate about fostering a supportive and educational environment for new nurses entering the unit. I would love to be in a position where I can serve as a preceptor, clinical educator, or even a charge nurse, helping to shape the next generation of critical care professionals. My ultimate goal is to not only provide the highest level of direct patient care, but also to contribute to the overall excellence of the nursing team and the safety of our patients.
What do you believe is the biggest challenge facing critical care nurses today?
I believe the biggest challenge facing critical care nurses today is the increasing complexity of patient acuity combined with the risk of burnout. Patients in the ICU are surviving more severe illnesses and traumas than ever before, thanks to advanced medical technology and treatments. This means nurses are managing patients with multiple comorbidities and complex needs, such as those on ECMO, CRRT, or advanced mechanical ventilation, all of which require a very high level of specialized knowledge and constant vigilance. The cognitive load and technical demands on the nurse are continually rising. This growing complexity places immense pressure on the nursing workforce, and when coupled with ongoing staffing challenges, it creates a perfect storm for burnout. Critical care nurses are often expected to provide a high standard of care for more complex patients without a corresponding increase in resources or support. The emotional toll of caring for critically ill patients and their families, combined with long hours and high stress, can lead to compassion fatigue and burnout. To address this challenge, I believe it is crucial for healthcare systems to invest in robust training programs and mentorship initiatives to ensure nurses are equipped to handle these complex patients. Additionally, fostering a supportive work environment where nurses feel empowered to speak up about their workload and have access to mental health resources is paramount. As a critical care nurse, my responsibility is not only to provide expert care, but also to be a resilient and proactive member of the team, advocating for both my patients and my colleagues to ensure we can sustain this demanding profession and continue to deliver the highest quality of care.
How do you stay current with the latest evidence-based practice and research?
Staying current with the latest evidence-based practice and research is not just a professional responsibility, but a fundamental part of providing the best patient care. I approach this proactively through several key methods, ensuring my knowledge and skills are always aligned with the highest standards in nursing. My primary method for staying updated is through a combination of formal and informal learning. I make it a priority to regularly engage with peer-reviewed nursing and medical journals, such as the Journal of Clinical Nursing or the New England Journal of Medicine. This allows me to keep up with the latest research findings, clinical trials, and emerging best practices. I often focus on topics directly relevant to my specialty, like new guidelines for managing sepsis or innovations in wound care. I also leverage online resources and databases like PubMed and the Cochrane Library to conduct focused searches on specific clinical questions I encounter in my practice. Beyond reading, I am a firm believer in lifelong learning through continuing education. I consistently attend professional conferences, webinars, and hospital-led in-service training sessions. These events provide a platform to learn from experts, network with other nurses, and gain a deeper understanding of new technologies or procedural changes. Furthermore, I actively participate in unit-based quality improvement projects. This hands-on involvement allows me to apply evidence-based principles directly to my practice and contribute to improving our unit's protocols. This multifaceted approach ensures that I am not only aware of new evidence, but am also able to critically appraise it and seamlessly integrate it into my daily patient care. What is your philosophy on family-centered care in the ICU, and how do you implement it? My philosophy on family-centered care in the ICU is that the family is an integral part of the patient's care team, not just a visitor. I believe that including and empowering the family is crucial for the patient's emotional well-being and recovery. In a critical care setting, where patients are often unable to communicate, the family serves as a vital bridge to the patient's preferences, history, and personality. It is my responsibility to not only care for the patient, but also to support their loved ones through a highly stressful and frightening experience. I implement this philosophy through a few key actions. First, I focus on communication and transparency. I make it a priority to provide regular, clear updates on the patient's condition, avoiding complex medical jargon and answering their questions honestly and with empathy. I believe that a well-informed family feels more in control and is better able to cope with the situation. I also actively involve them in simple care tasks, such as assisting with oral hygiene or providing a gentle touch, as these small actions can be incredibly therapeutic for both the family and the patient. Furthermore, I advocate for their presence at the bedside and facilitate their participation in multidisciplinary rounds whenever possible. This ensures they feel heard and respected as a part of the decision-making process. I recognize that a patient's recovery journey extends beyond their physical health and is deeply connected to their emotional and psychological state. By treating the family as a collaborative partner, I not only reduce their anxiety, but also help to create a holistic and supportive healing environment, which ultimately benefits the patient's long-term outcome. My approach is to be a compassionate guide and a reliable source of information and support for the entire family unit.
How do you build trust and maintain professional boundaries with patients and their families during a difficult time?
Building trust and maintaining professional boundaries with patients and their families is a delicate but crucial part of my role as a critical care nurse, especially during a difficult time. My approach is founded on the principles of compassionate communication, transparency, and consistency. I begin by establishing trust through clear, honest, and empathetic communication. When I introduce myself, I do so with warmth and sincerity, making eye contact and using the patient's and family's names. I take the time to sit with them, if appropriate, to show that I am fully present and listening. I explain procedures and treatments in a way they can understand, avoiding complex medical jargon. I am always honest about the patient's condition, both the positive and the challenging aspects, while offering hope and reassurance that the team is doing everything possible. This transparency builds confidence and shows them that I am a reliable and trustworthy source of information. Simultaneously, I am very intentional about maintaining professional boundaries. I am a caregiver, not a family member or a friend. I ensure this is clear through my actions, tone, and language. For example, while I am compassionate, I do not engage in overly personal conversations or share my own experiences. I keep my interactions focused on the patient's care and the family's needs related to that care. I also maintain consistent behavior with all patients and families, treating everyone with the same level of respect and professional detachment. If a family is becoming overly reliant on me for emotional support, I gently and professionally redirect them to the social worker, chaplain, or other hospital resources designed for this purpose. This dual approach of building a foundation of trust through genuine empathy while upholding professional boundaries ensures that I can provide the best possible care for the patient without compromising my own professional integrity or the patient's safety.